Thanks for watching. This has really been a great method to reach out to people. Like she said, we'll have an opportunity to have questions at the end. Th- this, for people who have seen me talk before, this talk is certainly has overlap with some of the stenosis talks I've given in the past, and it's because like in some ways these are two sides of the same coin. Although this includes other diagnoses that can lead to similar symptoms. And so the whole idea is here to give you a sense of, what this is, how it's treated. A lot of times these things are really not managed with surgery from the get-go. And so it's to give you a sense of what are the treatment options, and when that's exhausted, is there a likelihood that surgery will help you. So in general, sciatica is like sort of a medical word. Like I would say it's like quasi-medical. What it really is meant to mean is pain beginning in the butt that goes down the back or the outside of the thigh, and then the back or the outside of the lower leg, and can be into either the top or the bottom of the foot. And while it's possible this comes from something going on like in the pelvis, or there's one condition which people like to talk about, but very rarely actually occurs, that's in the buttocks. Most of the time, statistically, pick your number, 95, 96% of the time, this is from something going on in the lumbar spine. And specifically, it's one of a few different processes which can pinch a nerve. And, the pain and the weakness and the numbness you're seeing is the effects of that nerve not functioning normally. And we'll talk a little bit about what those things can be. And so in a nutshell, that's sciatica, is nerve pain, but specifically down the back or the outside of the leg. The two nerves that are involved are either L5 or S1 nerve, and this schematic's not great. There's something that shouldn't be there, but this nerve is the L5 nerve. This nerve is the S1 nerve. You can see that after they leave the spine, they briefly enter the pelvis, somewhere right behind this muscle, which is the piriformis muscle. They've joined together and they form the sciatic nerve, and that's obviously where the term sciatica comes from. This nerve services the back and the outside of the leg, which is why that pain pattern is what you tend to see with sciatica. I want to pause here for 1 second to talk about piriformis syndrome. Piriformis syndrome is an exceptionally rare clinical entity, like syndrome, that I have maybe convincingly seen like once or twice in my entire life. I don't have any understanding of why it occupies such a disproportionate, or like its footprint in people's minds is huge, and its footprint in reality on people's symptoms is pretty small. And really what it comes, in every single person, almost every single human, the sciatic nerve runs underneath the piriformis muscle, which here is drawn much bigger than it is. It's probably only a third of that size. And in situations where people have lost enough of their body fat, this is extreme weight loss, like people usually that have an eating disorder or are, have cancer that's leading them to waste away. You lose enough of your body fat, including the normal fat sheaths that follow nerves through the body, and that muscle starts rubbing on the nerve. The orientation between the piriformis muscle and the sciatic nerve is about the same in everybody. The only difference is people who actually get piriformis syndrome have lost tons of body fat, and you just hardly ever see it. And so most of the time, it's not that you have piriformis syndrome, it's that you have sciatica from something in your spine. The sort of more medically accepted term is radiculopathy. Radic is the Latin root for nerve root. Radiculopathy, therefore, is pain or weakness or numbness associated with a nerve root in this case, from the low back. Now, all sciatica is radiculopathy. Some radiculopathy is sciatica, meaning if the nerve roots in the low back, which are not L5 or S1, are irritated, you get nerve pain. It's just not called sciatica because it doesn't go down the back of the leg like that. So we're going to talk a little bit about how common a problem this is. I want to talk a little bit more about the definition of what sciatica is, specifically talking about the non-pain symptoms that can accompany it. There's a few distinct types, and by what that really means is like what is pinching the nerve. There's a few different things that can do it. Signs and symptoms, how you treat this, and then really bringing it up to mention that you really usually don't need fusion surgery. I want to mention a little bit about the times when you might need a fusion surgery, but it's the vast minority. All right, so how common a problem is this? This is the most common reason for lumbar surgery in the United States and in the world, hands down. A lot of people have lumbar stenosis, and there's a difference, and we'll talk. I think there's a slide on this a little later as well. But there's a difference between people who have lumbar stenosis if you get an MRI and people who have symptomatic lumbar stenosis. So the number of symptomatic stenosis probably is far less. 3% of Americans will experience symptomatic disc herniation. A disc herniation, is something that often comes and goes, and luckily 3% of Americans don't need surgery for that. 1 in 1,000 individuals 65 years old plus have had surgery for stenosis. That's a huge number. It's will become an even more impressive number, even if that percentage holds as the baby boom moves entirely into this group. There are already a lot of them in there, but the tail is still not in this age group. There's 200,000 surgeries a year for disc herniations. Cumulatively, the annual surgical treatment only of lumbar stenosis, lumbar disc herniation that cause sciatica is two big ones, 2 billion. So what exactly is this? And I alluded to it before in those first slides, but sciatica is pain predominantly. That's really what the term kind of means, but accompanying it very often is weakness or sensory changes that's either in one or both legs, depending on whether the nerves on one or both sides are affected, due to something pinching the nerve. Now that is a little bit misleading, and I probably should change the wording on that. It doesn't. There are a percentage of people who have clear nerve pain, but down the back of the leg into the calf, same as anybody else, but they don't have their nerve pinched. There is sort of an inflammatory, irritable nerve group of people, and those often are a little bit more difficult to manage because if the first pass things that we do without surgery don't work for them, there's really not a surgical option because you can't make a nerve that's not pinched, less not pinched. The compression of the nerves can be from a variety of things. It very commonly, and this is in stenosis, is arthritic changes that can be bone spur formation, overgrown ligaments. You can have slippage between the vertebra that that contribute to pinching the nerve just by changing the geometric shape of the spinal canal that runs between vertebra, and that you can think of also as along the arthritic lines. And then the last one is a little bit of a distinct problem, which is disc herniations. That's something that anybody can get it, but it's the problem that you tend to see in younger population that really hasn't had the same amount of time to accumulate the degenerative changes that lead to spinal stenosis. All right, so let's talk about a few different types of problems that cause sciatica. Again, sciatica being pain down the butt and the back or the outside of the legs. So central stenosis, if you can see I think you can see my cursor, is describing narrowing in this central tunnel that runs through the middle of the vertebra and the lumbar spine. And that can be from, if you look down at this bottom diagram, there's a combination on this patient that's a disc bulge in the front that's pushing backwards from the front, takes up some of the room. This is probably, it's a little bit hard to see on an MRI, but this is probably a bone spur that's coming off the joint that connects the arthritic vertebra together. And then certainly this stuff here looks like overgrown ligament, which is the body's response to our degenerative changes, trying to stabilize the level. And so all three of those things, which are like sort of misguided attempts by the body to stabilize an arthritic level, end up taking up space that's supposed to be allocated for the nerves. And once those nerves are pinched, in some cases cause pain down the leg. And central stenosis can cause symptoms in any nerve that's in the spinal canal running through at that level. Foraminal stenosis is the other type of stenosis, and the foramen is the name given to the nerve tunnels. So this is something that happens, it is largely the same processes, arthritic bone spurs, overgrown ligament, disc bulging or herniation, that narrows that nerve tunnel. And this would only affect the single nerve that's leaving on that side. So it would be a single side problem and a single nerve pattern. And again, when that's the L5 or the S1 nerve that's pinched, it becomes sciatica. And then the last thing is, well, not the last thing, but the last thing we're going to cover, last common cause of this is disc herniation. And so the disc material is the shock absorber, essentially the spine, and sits between the vertebra. the material, as you can imagine, to do a job as a shock absorber has to be sort of soft and squishy, and that's what it is. It has a consistency that's sort of like it's like crab meat. It's like solid, but it's sort of stringy and soft. But it ends up being firmer than the nerve, and can when it gets in the wrong spot, it can pinch the nerve. And so if you look at this top picture, if you look at the right side, this is the spinal canal, and that's the nerve root that's going to leave at the next level. If you look at the left side of the screen, like God knows where that nerve is, because this big round blob here is a big loose piece of disc which has been spit out from where it should be and is sitting on the spinal canal and is pinching that nerve. You can imagine like this thing is somewhere in that black area, and you can't make it out distinctly, but that pinches a nerve and causes pain on one side because the disc herniation is off to a single side, probably in just one nerve. All right. So those are kind of like what we're up against in terms of fighting off sciatica. I've talked about this a little bit about what symptoms this causes. Now, one thing that's really important to keep in mind is that we do not treat the MRI. And the reason you don't just treat the MRI is it's very common for people to have findings on an MRI that really just doesn't match up with symptoms. And so that's one of the things that we hammer in the office when we're meeting someone for the first time or who's been living with leg pain, trying to get as precise a description of what part of the leg is affected. And the reason is because if this person is very tight or at L4-5, if they have pain in the front of their thigh, that doesn't match up. The L5 nerve and the S1 nerve, which are pinched, which we've been talking about, make sciatica and goes down, like I said before, the back or the outside. So if you have front of the thigh pain, that isn't it. And going in and doing a surgery there will not make them better. And so you got to cast a wider net and start figuring out what is causing it. Is it something higher up in the lumbar spine? It could be, or is it a bad hip or something like that. And many people are asymptomatic, and so we don't want to go fixing the MRI. You got to fix the person. So radiculopathy, I had that up before. That's really just a description of symptoms that come from a nerve getting pinched in the back. Sciatica is one type of it, but it's leg pain, weakness in a muscle, or numbness based on which nerve is pinched. And so, for instance, the L5 nerve, which is a part of the sciatic nerve, is the principal nerve that gives the nerve supply to the muscle that pulls your foot up. And so in bad L5 radiculopathy or bad sciatica cases, sometimes people will get a foot drop. In contrast, the L3 nerve, a couple levels up the spine, the nerves there run to the front of the thigh, and that's where the pain distribution is. And that's the most important nerve. L2, 3, 4 all contribute, but L3 is the most important to giving you strength in your quadriceps. And so that's a very disabling problem. People who have weakness in their quadricep can't ascend or descend stairs. They have trouble sitting up from a seated position just because their legs aren't that strong. Classic story of stenosis leg pain, stenosis sciatica, is worsened with walking or standing, and people get better sitting down or leaning forward because it makes a little bit more room in the spinal canal. When you have lower lumbar disc herniations affecting the sciatic nerve specifically, very often sitting makes it worse. And the reason it has to do with the diagram I showed at the beginning, in which it shows the sciatic nerve traveling right down like the butt and out the back of your thigh. And so when you sit on it, especially on a hard chair, or if you're really loading it like on a toilet seat where your butt's free and your thigh is pushing on the seat, you can really irritate the nerve. And sometimes people have a real hell of a time driving a car when they have sciatica or L5 or S1 nerve compression because it makes it so much worse. Oops. Okay. So and this I mentioned this a minute ago, but this is why we're so focused on trying to ferret out exactly where your pain is, because different nerves go to different areas, and you need things to match up on the MRI with the part of the body that should be affected. Otherwise, the person's not going to get better with the surgery. And I don't have a map here, but different nerves also run to different muscles. The L5 controls the foot drop, L2, 3, 4 control the quadriceps, and so forth. So very rarely, with either big lumbar disc herniations or severe spinal stenosis, you can get compression of the nerves that are the S2, 3, 4 nerves that leave the spine at the very, very base of the spine that control bowel and bladder function. Most of the time, I mean, there's a lot of things that can cause difficulty with leaking urine or urinary retention, or and there's a lot of times very gender specific things. Women tend to have more pelvic floor problems, sometimes associated with childbirth. Men frequently have urinary retention and difficulty urinating consistently and strongly because of the prostate. And so there's a lot of things that cause it. It's not commonly the spine, but that's a very serious condition when it is the spine. And so it always raises a little bit of a red flag for us. One thing that's important, pinched nerves from a disc herniation, nerves that are compressed from spinal stenosis in general are not causes of back pain. Now, the same arthritic degenerative processes that cause a bone spur to form and pinch a nerve and cause leg pain, that level is arthritic and may be associated with back pain, but fixing the bone spur doesn't fix the back pain. The arthritis is something that we really don't do we don't have a good track record in terms of fixing with surgery. And so most times, whether you got a pinched nerve or not, if the main problem is back pain, I tell people to stay the heck away. All right, so talking a little bit about so, oh, never mind. Sorry. I thought I forgot to make another slide. Okay, so natural history is a term that's used in medicine to describe like what happens if you don't do anything, meaning like you let it run its course. How does it turn out? And so in a 4-year history, this is old, but it's a very good study because it included a ton of patients that they just let it ride. They tracked them, they saw them in the office, but nobody got an operation, nobody got any intervention. And in general, like the biggest groups are like they're about the same. 70 their general health and general feeling of their activity level, they're about 70% are about the same 4 years later. Pain level, 58% are about the same. And actually, look, there's a decent percentage that feel like they were better off, whether they're just getting used to it or whether there is something that improved is hard to say. But in general, the story is not bad. Walking, there's a higher percentage that did better. There's a higher percentage that did worse. A little bit lower percentage is about the same. But again, like kicking the can down the road in this situation is doesn't necessarily mean it's going to come to something bad. When it gets bad and you can't manage it and you can't, it's the quality of life's in the gutter, then you fix it. But it's very rare for this to turn into something bad. No one got paralyzed. No one ended up in a wheelchair. Very, very rarely do people get bowel and bladder problems. And when it happens, you fix it. And it's a serious issue, but it doesn't happen often. There's a million, I didn't pull a specific study for this because there's a million studies that show like the biggest story with disc herniations is not about whether the surgery is successful. Surgery is somewhat more successful than not treating it with surgery. But the real story is 90% get better in a couple months if you don't do anything. And so this is they try everything but surgery first. Usually you can ignore this for the most part and it'll get better. Now, if people are really in duress and in a ton of pain, then you got to do something to help them live through it a little longer and hope that they can. And there's obviously situations where either they get weak or they just can't stand the pain anymore and it's ruining their life, and then you go and you take the piece of disc out. Okay, so treatment. So again, beginning non-surgical treatment, especially for disc herniations, just time often makes it better. And the mechanism for that, the reason that works is because the body can break down the disc herniation, absorb the disc herniation material, and it goes away. And so it doesn't pinch the nerve anymore. Anti-inflammatory medications are often a first line of defense here. Nerve pain medications, there's 2 in the United States, Lyrica or pregabalin. The second one is gabapentin or Neurontin. Those don't work for everybody. They can be very successful for some people. It's a pretty favorable side effect profile, despite if you read the package, I don't know why it's so bad. If you read the package insert for these, it's like every affliction known to man. But the reality is for Lyrica, sometimes we see weight gain or water retention. And for gabapentin, my take on it is like 20 or 25% of people, it tends to make them like sleepy or feel like they're cloudy, and then you really can't use it. Physical therapy is really something that's used more for back pain. Once in a while, we'll do it for stenosis pain just to strengthen the back in the meantime. But strictly speaking, it doesn't usually make a big difference for leg pain. Epidural injections are particularly useful for disc herniations because of the temporary nature. For the same reason, when you have structural things inside the spine that aren't going to go away, like a bone spur pinch in the nerve, it's sort of easy to understand that why an injection may not last. And that's what what the studies have borne out, which is that for bad spinal stenosis, epidural injections only rarely do not typically lead to surgical avoidance. And then there's all sorts of alternative therapies, and there's like some that are weirder than others. I always tell people, if you got the fight left in you to try it and it seems weird, as long as it's not going to hurt you or cost a lot, give it a go. We try to avoid laying around in bed, and we try to avoid narcotics. And a word quickly about pain medications. And there are things that pain medications are important to treat. The pathways in the brain that you experience nerve pain, though, are not particularly responsive or not particularly sensitive to narcotics. It works kind of through different pathways. And so, pain medication like Percocet may be great if you break your ankle. It doesn't tend to be as successful for sciatica. All right, if you fail everything, you're still going through it, you can't walk, can't go to work, so whatever the circumstances are, then that's when you would talk about a decompressive surgery. And decompression is a generic term that means taking the pressure off the nerve somehow. It doesn't really tell how you do it. The two big workhorses for this type of thing are laminectomy. That means taking away the whole lamina. And if you look at this bottom left, the lamina is this piece of bone that kind of spans side to side in the back. This is the back of the spine. This is the front of the spine. And so laminectomy is going in there and basically taking away a strip of bone. You can see here the finished result, taking away two strips of bone, two-level laminectomy, to be able to get into this place where the nerves travel. That's what this is supposed to represent, like the sac that carries the nerves through the spine, to either take away the bone spurs and the disc herniations, or to widen the nerve tunnels off to the side where the nerves are leaving the spine, which is these yellow things coming out the side. Laminotomy means you take away, usually only on one side, and you just take away some of the bone. You don't take like the whole strip. It would be like taking away like this. You usually take a little bit from each side. And that's when you have a more focal problem that you don't need to really open the entire canal. So this is what I tell people. This is laminectomy, laminotomy, discectomy, microdiscectomy. All that, they kind of all mean a similar thing. That it varies really with respect to how much bone you need to take. But where the rubber hits the road on these is whether the legs get better. And that's a very high success rate. When you have a leg pain that matches up with where the nerve's pinched, we win 90+% of the time. Hopefully in a setting where you don't have to you're not putting any foreign object, no screws, no rods, no metal, that has a very, very low risk of an infection because there's no foreign objects. The most common complication of this surgery has to do with getting a spinal fluid leakage. That's like, again, looking at the diagram, this yellow sac that's traveling through the middle of the spine, in reality is very, very thin walled, number one. Number two, most spine surgeries, not all, but most spine surgeries require you to manipulate that sac to a certain degree just to get to where the bone spur is, to get to where the disc herniation is. The nerves are very tolerant of being moved like that. But with that flimsy sac covering them, about 1 in 20, you just like get a nick or a hole in it from moving it around. And it doesn't affect the nerves, but it allows spinal fluid to leak out. So you see it during the surgery, you sew the hole closed. The realistic biggest downside of that is like if a lot of the fluid leaks out before I can get it patched up, you can get a spinal headache, which is something usually it's front of your head or top of your head. It's positional. So you sit up or stand up after surgery, you get it. If that's the case, we know that you lost too much fluid, will make you lay flat. The headache will go away. Most importantly, though, with that hole already closed, the brain constantly makes spinal fluid, and within usually like 5 or 6 hours, you can kind of catch up with what you lost, and the headache should go away. Most severe complication, there's no spinal cord for the majority of lumbar spines. You can't get paralyzed, you can't get a spinal cord injury, but you have about a 1 in 1,000 risk of getting an injury in one of the nerves. And that's exceedingly, when that rare chance that happens, that's almost always like a stretch injury. You're moving things around, trying to free it up, and inadvertently you stretch it more than it wants to be stretched. And that would lead to weakness wherever that nerve goes. So if that's L5, you get some degree of foot drop. And it doesn't mean it's completely weak, but it would be weaker than when you went in. Now, thankfully, because again, these are mostly stretch injuries, so it's not like the thing's cut or something like that, that recovers over time on its own, just with time and physical therapy. And usually 1 or 2 nights in the hospital, it's a 1-level procedure that it could be done as an outpatient, sometimes 2-level procedures done as an outpatient. All right, a couple other things. I should actually update this talk also to include, there's this thing called a mile procedure. This is not a mile. This is an actual chunk of metal that you basically open up just the part of the spine just closest to the skin, which is these little spinous processes, these fingers of bone that push backwards, and you jam this chunk of metal in there. And the idea behind it is it's supposed to like spread the vertebra apart in the back a little bit and maybe open the nerve tunnels, which are kind of, you can see right here, like nerve tunnels are kind of close to where you jam it in. So maybe it opens up those nerve tunnels a little more. These things have been around. This X-Stop is one of the devices. I think it's come and gone. I don't think it's available anymore in the market, but this is like the Phoenix. It rises from the dead. It's around a little bit. It dies again because it doesn't really work that good. And then eventually someone, recreates the wheel and brings it out again. So there's been and I've been in practice 13 years. There's probably been like 3 to 4 iterations of this. They're still around, and there's probably a percentage of people that they work for. That what ends up happening though is you got bone is hard, but it's not as hard as metal. And what the most common pattern is, if people get relief from this, they get it for a while, and then the thing cuts through their bone and wiggles loose, and it's not separating them anymore, and then the symptoms come back, and we got to go there and throw that thing in the trash where it belongs. So it once in a while it works. There's probably rarely a reason to do it, but and the reason is just because the surgery that works, like I just showed you a couple slides ago, is just so tried and true. It's hard to improve on it. All right. So there's sport trial was a really well-funded study by the NIH, which basically took people who had spinal stenosis, disc herniations, and then there's one other group that is not really relevant to this talk, and they had these patients either get treated with surgery or without surgery, and then they followed them for like, I think they're up to like 8 years or 10 years. So it's the best evidence we have about whether surgery works for these conditions. And in 2 years, I can extend this out to 6 years. Patients who had surgery for either spinal stenosis or a disc herniation had less pain than if you didn't, and better physical functioning than if you didn't. Now that isn't to say that people who didn't have surgery did terrible. That's not true at all. Most times they had small improvements, less improvement than with surgery, but improvements nonetheless. There's very little evidence that delaying surgery led them down some bad path. This study, which had thousands of patients in these 2 arms of it, had nobody who developed severe weakness and was wheelchair bound or like lost the ability to walk or anything like that. And so those things are sort of like the boogeyman. Do they ever happen? I mean, they do happen occasionally, but they're rare enough that should not be a motivation to do a surgery. The motivation to do a surgery should be quality of life because you're sick of living with it and it's stopping you from doing stuff you want to do in your life. Okay, so what about fusion? There are some things that require that not require that you probably ought to do fusion surgery for. And this top one is the one you see the most. On this is an X-ray from the side view, a side view. L4 and L5 vertebra are not lined up. And what's more, this black line right here that goes right through what should be the back of L4. You can see here, there's no black line, right? It would be like in that area. That black line that's going through L4 is a fracture, is a break that this person probably got as a kid. It's often a stress fracture that turns into a full-blown fracture. The issue here is that going in and doing a laminectomy on this person, if they had spinal stenosis, disrupts the little bit of stability that they have at that area because there's no bony stability, and the surgery often makes the slip worse. And so in that setting, your kind of hands are tied. You can fix it all the same, and you got a good chance to get rid of leg pain, but you got to put in screws to keep that person from shifting more. And this is not really that bad of scoliosis, but in bad scoliosis, that's a way to straighten it and to try to bring people more upright. Now, most of those surgeries are not done actually for the curve you see from the front. They're done because as people get really bad scoliosis, they tend to lean forward, and that really drives people crazy and is really painful. So it's more about that. This one of the topics of this talk is disc herniation. Disc herniation, if you get a disc herniation once and you can't shake it and you want to have surgery for it, you go and you take it out. If you get a disc herniation a second time and you try to do everything and you can't live with it and you go in and you take it out, you just go in and take it out. When you get it a third time, very often the conventional wisdom is to fuse it. And it's not really a medical reason. It's more of a practical reason. It's like okay, we know this level keeps popping out loose pieces. Like how many times are you going to go through this, knowing that each time it's a little riskier and a little harder to fix the problem and a little bit less reliable results. And so a lot of surgeons on the third disc herniation at the same level will do a fusion surgery. Tumor and trauma are totally unrelated reasons. Spinal stenosis in the thoracic and in the lumbar spine is not a reason in and of itself to do fusion. You don't fuse a level, you don't fuse vertebra just because you decompress it. And it doesn't matter how many, if you have L1 to S1 laminectomy, you still don't need to fuse anything. It's not about the number of levels. You only fuse if there's a reason to suspect that it will become unstable, either in the future because of the shape of the spine or because of the surgery itself. All right, and that is all I got as far as slides are concerned. So let's see. Now let me open the, oh, we're up to 220, geez. Okay, so I'm gonna open the chat room. The only person who wrote in there is Kristen.
No, no, there's the Q&A. Do you see that?
Oh,
I'm
sorry.
happy
Okay,
to.
sorry. Maybe I just don't know how to do it. Hold on. Let me look. Let me find it out. Where is it? Oh, is it the more? Oh, I see this. Okay, I got it.
On my
I got it. I
screen's
found it.
right
No,
now.
I found it. I
Okay,
found it. I
great.
found it. Okay,
So I'm
so
happy to go through them unless you want to go through and read them yourself, however it
no,
works
I'll
best
just read
for
them
you.
out. I think
Okay.
that's just less cumbersome. Okay, so this is a good thing to put in. This is making my talk better too. So thanks for the hints. This is from anonymous attendee. Says, what is the average time frame for recovery from lumbar decompression surgery with laminectomy? So that's a great question. I think that this is like a 6 to 8 week gig. And what you're really asking, there's sometimes two things rolled into this. One question can be like, my leg is weak, how fast is it going to get better? That's a much more nuanced discussion. Has to do with how weak you are, how long you've been weak, how many different nerves that may contribute or are compressed. And that's not something I can really answer because it's way too specific. But I think probably what this is getting at is like, what does it look like when as the dust settles on the surgery? The way it looks, just flesh it out a little bit. First day or two, you feel rotten. Your back hurts a lot. Even if it's a little bitty incision, it's going to hurt more than you think. That's going to get better though. 2-3 weeks in, that the back pain at the incision will be substantially better than it is those first couple of days. Still like you'll be walking around like Frankenstein, stiff and sore and stuff like that, but active. You can drive a car as soon as you feel up for it. Usually that's a week or two. By 6 weeks, we lift the restrictions on you, bending, lifting, twisting. Most people are kind of feel like they're over the hump. Now, if you have 10 levels decompressed and it's a huge incision, then it's a little bit different, and you got to probably take like a 25% penalty in terms of time to be back in the game. But I think it's like a 6 to 8 week thing. 6 weeks, I let people start exercising with the goal of at 8 weeks, be able to do whatever you want. Okay. Why do I have no sciatic pain during the morning, but going in the afternoon it becomes uncomfortable? It probably is from being up on your feet and from, when you're just awake and doing stuff, that tends to be in positions and with activities that makes the stenosis, the pressure on the nerve, slightly worse. And so you're just accumulating inflammation throughout the day, and at some point it passes the threshold where the nerve starts sending these errant signals to your brain that said like it hurts down here, and then it catches up with you. And so if you could, again, activity modification sometimes can be a strategy, or if you can find a time in the middle of the day to sit down and not do a heck of a lot, you may be able to save your afternoons to some extent. But I think that's the reason that we tend to see that. It's getting irritated throughout the day. If my pain can be controlled by Lyrica, epidural injections, Advil, and marijuana, is surgery worth the risk? I mean, that's up to you. Probably not. Like if you're not limited in your life, and the treatments that you use to get to that point are not like particularly bothersome, and you don't mind doing them, yeah, why would you do surgery? I wouldn't do it. Can exercises bring on sciatic pain? Sure. And the context for this again is like it has to do with what part of the body hurts. But L5 and S1 sometimes just like stretching hamstrings or things that lean forward can put a little bit of stretch on the sciatic nerve and can irritate it. Exercising that, like sometimes people get it with recumbent biking just because again you're sitting for a long time. So anything that either irritates or stretches the sciatic nerve could bring on pain. My son is 28. His sciatica is painful, and we've done this down his leg. MRI shows degenerative disc disease. He's been told no surgery. It's altering his life. He's had 3 shots. So, what else can he do? The It depends a little bit. Like the MRI shows degenerative disc disease. If the MRI also shows that a nerve is pinched, then then he may be a surgical candidate. The big line in the sand is if the main pain that he has is at the waistline or the belt line, like meaning back pain. That's something that like it's difficult. The surgeries you use to treat back pain are like putting in screws and rods and fusion, and we don't like doing it in particular because it has a success rate for back pain that's like 50% or 60%. It's not very good. And so that's what you were told that he's not a surgical candidate. If he does have symptoms though that are in the butt and the leg and something's pinching a nerve, then he would be a surgical candidate. I lost weight and it helped with my sciatica, but now feels like Thanos is squeezing my left testicle. When I lay in my back or crack my when I lay in my back or crack my lower back, it helps. Should I be worried? I mean, I don't think so. I like you should be worried if it's Thanos, but if this is sciatica, it's probably not different from the standpoint of like what's going to happen down the road than it would be if it was in your back or your leg. But it probably is from something getting pinched in your back. So I don't think there's any like warning signs in your story, other than it sounds like a little bit of a miserable thing to be going through. I believe you mentioned issues with the hip and also got sciatic type pain. Can an injury like hip labrum tear impact sciatic pain? No. Really what I was referring to was the whole piriformis syndrome thing. Hip labrum is not close to the sciatic nerve. Like some surgeries to fix hips and can get near other nerves, or if you're going from the back, could be near the sciatic nerve. But there's the surgeries designed to avoid all the nerves. So it should, but a hip injury like a labrum tear cannot cause sciatic pain. What alternative therapy methods may help? It's like kind of chiropractic manipulation, acupuncture. I always send people to. There's like kind of this like newer wave of stuff that's like like the cupping and dry needling, which isn't exactly acupuncture, but it's sort of like interventions. In Jersey, you hear a lot about prolotherapy, which like that's one I'm not exactly sure why it should work, but sometimes people say it does. So again, it's like some of these things I would have less faith in than others, but if you got the bandwidth to try them and they don't cost that much, I would do everything you can do before you do surgery. Might you have any suggestions to relieve the pain while sleeping? Sometimes position, like sleeping with a pillow between your knees on your side, sometimes that relieves pressure in the sciatic nerve, and so it may make symptoms somewhat better that way. The other thing, sometimes one of the side effects of gabapentin, like I mentioned, is sleepiness. Sometimes we give people gabapentin pill just one before bed, and it treats the sciatic pain to some degree, and it also may make you sleepy. And in that setting, that's not a bad thing. Once foot drop occurs, will surgery restore function? Definitely, probably. No, I mean, so when you get weakness and it's persistent, you probably, and you have a nerve getting pinched, you're probably headed for an operation. The less severe the foot drop is before you do it, the shorter length of time that you've had it before you do it, the better it'll turn out. Recovery of strength is always lower odds than getting rid of leg pain. Like I said, we live in the 90+% area for pain. I think depending a little bit on the circumstances, but I usually tell people for weakness, if you get to it before it's too bad, it's probably like in the 75 percent range. That's sort of made up, but something like that. How often can you get an epidural steroid injection? Is there a lifetime limit? No lifetime limit. I think that has sort of a practical answer right now, which is that most insurance companies really don't want you to do it more than once every 3 months, and that includes Medicare. No lifetime limit. It's most of the steroid is kept locally where it's injected. There's very low systemic absorption, meaning there's not much of it that gets absorbed into the bloodstream and travels throughout your body, which is where you get into trouble with all the bad side effects of steroids. Can you have stenosis or sciatica without pain down your legs? I have ache and pain in my hips and lower back, not in my legs. Yeah, so sure. Yeah, I mean, depends a little bit what you mean by your hips, but like if you mean like on the outside, like where the pocket of your jeans is, that's a really common place for L5 nerve pain. It doesn't have to run all the way down. And there's a lot of people who the primary manifestation is really bad buttock pain. So it doesn't need to make it like all the way down if it follows the same pattern and like you do, you have bad spinal stenosis. What do you do if there's weakness in the arms and legs? Number one, look at the neck. The only part of your spine that could cause both your arms and your legs to be weak is a problem in the neck. If the neck looks clean, you probably see a neurologist as the next step. How does Bartolotti syndrome affect sciatic problems? Not at all. So Bartolotti syndrome is when the side of L5 vertebra is sort of bigger than it should be and it rubs against the top of the sacrum. That does not take place in an area that affects the sciatic nerve. The nerves are not near that rubbing area. Bartolotti syndrome usually the symptom that people get with that is not a real common thing, but the symptom that people get with that is usually sort of like a deep ache in the butt or the low back. Does sciatica show dominant pain in the hip area and the side of the thighs? Yeah, so hip and the side of the thigh is L5 nerve pattern. So if your L5 nerve is pinched, that's where you get it. If your S1 nerve is pinched, you'd get it in the butt and then in the back of the thigh, not the outside. If your pain is mostly in the buttocks, does that indicate sciatica? Yeah, it can. A buttock is difficult in one sense, which is that there's a couple different things that can cause pain that people describe as buttocks pain. One is sciatica, nerve pinched. Now, classically, what you think of for that is like it sort of like makes it far enough down that it's like in the meaty part of your butt, if you will. The SI joint is in that area. It's kind of like more near the waistline, like higher up, and it's off to one side, about 3 to 4 inches off the middle of your back. And then to complicate the situation further is that if you have arthritic changes in the lower lumbar vertebrae, L4-5, L5-S1, that affects the joints that connect those vertebrae together, that can often create referred pain that's in the butt. So it can be sciatica. It doesn't always mean sciatica. And so when there's just butt pain, it usually takes a little bit of detective work to figure out kind of which of those options it is. Someone asked about they've been getting injections for 2 years. Are they healthy for me? I mean, I don't know if they're healthy for you, but I don't think they're doing a whole lot of harm if they seem to provide you with consistent relief of the pain that gets you through what you need to do. Can you continue indefinitely? In theory, I think the answer is probably yes, with some low risk of getting side effects from the steroids, but it's a pretty uncommon thing. And the one thing I'd say is that without knowing more about this situation, degenerative disc disease, L4, L5, and S1. So that strictly speaking, that kind of makes it sound like your discs are collapsed. If this is about back pain, then usually I recommend against surgery because it's a bigger surgeries that aren't real successful. If this in fact is pain from arthritic changes that goes into the butt and down the legs, and you've been doing it for 2 years and you're not happy with the relief you get from the injections, then it probably would make sense to have a surgery. What is the most likely source of upper hip pain on one side without groin pain, in addition to the low back? So most of the time, pain from a hip joint is in the groin. Pain on the outside of the hip or in the butt, well, on rare occasions, it can be sort of like an atypical pattern that goes along with pain. That goes along with hip arthritis. It's not very common. And so if you have an x-ray that your hip doesn't look bad and your pains are on the back, it's probably not your hip. It probably is your back. And L5 and S1 radiculopathy. If L5, S1 autofuses, self-fuses, pressure goes to 4-5 causing shrinkage. I guess the idea here is really a theory. I wouldn't say that the jury's back on whether that's real, but when you have two vertebrae that have grown together, the concept is like the next disc adjacent to that sees more burdens, like sees more load of your body, and it has to it has to do more for you, and that can cause the disc to wear out faster. It's not real clear that that's true. If it's real, it's a small percentage, but could it cause nerve pain and justify fusion? I mean, so if a nerve gets pinched because of arthritis, and it could cause nerve pain, sure. that would still not justify fusion unless, again, like I said before, there's some reason you need to do fusion. Instability, the vertebra shifting, it's a third disc herniation, it's something like that. You don't, a pinched nerve, for the most part, is not treated with fusion. One of the problems is lingering is numbness on the ball of my left foot. It's not painful, but it's noticeable. So, I mean, the ball of the left foot, if it's not something in the foot itself, which is a possibility, but we're kind of like going off not much of a story here, but it is from the S1 nerve. Unfortunately, numbness is the symptom of the three. Numbness, pain, weakness is the symptom that's least likely to get better, and also is the slowest to resolve. And so, like, if this is someone who, if you're someone who had a surgery and it's still there and you're 12 months in, it still could get better. If this is the only thing that was left over after you had sciatica and the pain went away and you're not weak, but you still have numbness, I mean, it could be a pinched nerve in the back. It might be there forever. If it's still pinched, it might go away, but we don't love doing surgery when the isolated symptom from a nerve getting pinched is numbness, because it's, like I said before, it's a symptom that's like the least predictable. Should something be done if cervical spine causes numbness in my hands? I mean, if you have spinal cord compression and your hands aren't working good, or they're numb, or you have trouble doing stuff, yeah, you need to get the pressure off the spinal cord. And it's not science, it's nothing to do with this talk exactly, but the answer is yes. And the reason is because it doesn't always get better. So you don't want it to get worse and then have surgery and not get better. And number two, the recovery of function is somewhat dependent on how quickly you do an operation. So once you start getting functional limitations from spinal cord getting pinched in your neck, you should fix it. Why does back pain temporarily go away once you sit down? It probably is just mechanical burden. You distribute the weight differently, especially if you have arthritis in the joints in the back of your spine. The upright posture where you're kind of leaning backwards in the low back with the sway back puts more pressure on it. When you sit down and your spine flexes, meaning leans forward a little bit, those joints aren't seeing that much burden, and so it probably doesn't hurt it as much. But once you walk a bit, there's no pain. Then after a while, it starts. Yeah, I mean, it probably is just mostly postural. Now, pain down the leg from walking that's relieved with sitting is because the seated position makes a little bit more room in the spinal canal, eases the pressure on the nerves, and doesn't hurt as much. All right. It's because I have frontal stenosis. Oh, so this is a follow-up. Oh boy, the original one's gone now. So just to paraphrase this question, is like the person's asking, was recommended to have a fusion surgery, and the reason they recommended to have a fusion surgery, it sounds like it's not because of instability or a shift or a third disc herniation or something, or scoliosis. It's because they have stenosis in the neural foramen. There is a subset of people who have that, where the nerves are pinched in the nerve tunnels from the top to the bottom because the disc is so collapsed. Like that space has gotten too short and the nerve's pinched in the middle. That in isolation is one of the few reasons why you need to have a fusion to treat stenosis. That is I think my opinion of the spine world is that is increasingly overdone, and spine surgeons are getting a little bit lazy and not chasing those nerve tunnels down to take the pressure off it with a much smaller surgery. And so, 15 extra minutes or 20 extra minutes of doing work, that's pretty hard. It technically is hard, but helping someone avoid getting a bunch of screws and putting their back seems like it's worth it to me. So there are situations where that's the right answer. I think that most of the time, lumbar foraminal stenosis, particularly if it's at the lower part of the lumbar spine, can be addressed without needing fusion. Will a laminectomy only relieve leg pain? What relieves lower back pain and butt pain? Butt pain should go with the leg. Back pain depends on the circumstances, but it's the likelihood that a laminectomy will relieve low back pain is very, very low. So I would say no to that. What relieves low back pain? In theory, first of all, every non-operative thing in the world, do that first. The only operation that's ever been invented that can help low back pain is lumbar fusion, and like I said, 5 out of 10 or 6 out of 10 odds, not great. Can you explain the symptoms? Can you explain the symptom differences from sciatic numbness, L4 below the knee, and foot numbness versus neuropathy? I don't totally understand it, but so Neuropathy is the nerves in the legs not working normally, and the pattern that is frequently used described is sort of stocking distribution, meaning like it's below, there's a certain level depending on how you got ankle socks or knee high socks that everything below that is numb. That's very different from the pattern you get most of the time when nerves pinched in the back, which is that you have thigh symptoms and then you'd have in wherever that nerve runs, you'd have numbness in that area. So for instance, if your L5 nerve is pinched, only the outside of your thigh and leg and the top of your foot would be numb. It wouldn't be like the whole thing. And so that's kind of the classic way we distinguish between neuropathy symptoms and numbness that may be from a pinched nerve. Is epidural injection a temporary deal or take care of the pain for good? Usually a temporary deal, with one common exception, which is that if you have a disc herniation and you get an injection and it makes the pain go away, because of the fact that disc herniations often resolve on their own, it may seem like it was forever. Now, that's more about the disc going away than it is about the injection lasting forever. Because epidural really just is an anti-inflammatory. Are there any regenerative medicine procedures that can be performed for these conditions like scoliosis and, sorry, people keep adding questions and it's jumping up. And I think spondy. No. Like, no. I run a basic science lab at Jefferson. It's basically like molecular biology lab, but one of the things we've studied is stem cell regeneration and the ability all these strategies are very limited by the fact that the disc is an inhospitable environment and barely has enough blood supply, or not blood supply, doesn't have a blood supply, barely has enough nutrients for the number of cells you have. Injecting stem cells into the disc that costs you $5,000, those things die. They just die. So do not waste your time in that. There's a reason Medicare and none of the insurance companies will pay for it. It's because it's not a real thing for the spine anyway. Okay. What if the nerve pain is down each leg, front, side, inner, back? Yeah. So is that multiple nerves pinched? Yeah, that's kind of the idea. Is if it's in multiple nerve patterns, either it's not from the back or you got to have multiple nerves pinched. Pregnancy corrected it. Huh. But now sometimes maybe we'll add that to my treatment slide. Only applied for women though. But now there's a herniated disc at L5S1, but I have nerve pain in both legs all around. That doesn't really jive with an L5S1 problem. If that's the only area where there's a nerve getting pinched, you probably should see someone to potentially get like an EMG to see if there's another cause of the nerve symptoms, because that does not provide a good explanation. Can sciatic pain affect the front of the knee? No, because the L5 or the S1 nerves don't go there. You could certainly have that. You could have sciatica if the L5 or S1 nerve is pinched, and if the L4's nerve is pinched, which goes to the front of the leg, goes to the front of the thigh, to the knee, and down the shin, you could also have symptoms there. Based on the stats, it appears that doing nothing is an option. Definitely. Is it a bad idea to power through the pain with exercise and stretching? It's not bad in the sense of like, you're not going to trigger some bad event to happen. I think that's what that means. Like if you do so much that you like got to spend the next day laying on the couch, like it's not such a practical approach to this. But the sciatic pain triggered by activity is not bad, other than you feel miserable. How long does it take to herniation to heal if you have sciatica for 3 months? So usually 2 to 3 months is the time when if people are 3 months in with the same symptoms and they're not really getting better, you start thinking like probably this thing is not going to happen and it's not going to go away on its own. And then that still doesn't mean you need to have an operation. It just means it makes things like epidural injection less attractive, because the only hope with that is that you ride it out and the thing goes away. So if it's not going to go away, you may get a couple months of benefit, but then it'll probably come back. It said that motion is lotion. Should you keep exercising with limited back pain? Yeah, as much as you can, really. I mean, again, like with that same example, like if you do too much yard work and then that's on Saturday and Sunday you gotta lay on the couch all day, and the Eagles aren't playing, that's kind of a bummer. So you got to kind of walk the line. In general, I agree that the more motion, more activity, more exercise, the better. To a point, as long as you're not really stirring up a ton of pain. Does acupuncture help with herniated disc? It doesn't help with herniated disc, but it may help with pain. I have a minimal disc bulge with annual fissure, and there's facet overgrowth. So there's I don't think there's anything that can actually make a disc herniation deviate from whatever course it is going to follow. There's no intervention. Exercise doesn't do it. You maybe if you could move to space, it would do it, but like that's about it. Um, and so I don't think there's any hope that acupuncture would help. But acupuncture is really, I would think of as a way, and I believe in it. I think it's more of a way to manage symptoms of pain. I think that's really what it would be. I would believe that it could do. Um, I would told my doctor you can only have sciatic pain on one leg at a time. That's wrong. But I have it in both legs at the same time. Just wondering whether having both is rare. No, not at all. If the nerves on both sides are pinched, then you got it on both sides. So that doctor's wrong. What sleeping position helps sciatic pain? So relieving the pressure on, you can relieve some of the pressure on the sciatic nerve with a knees bent, hips bent. So it's like kind of like the fetal position. And then I think usually having a pillow between your legs is probably about as good as you can do. And it may not, like that's how you can take the pressure off the nerve. That may not be enough to save the day if you're really going through it and the nerves pinch badly. I'm having pain in my calf and they're saying it's coming from my back. The pain is so bad I can't even walk at times. Thoughts. I mean, that sounds like neurogenic claudication is the name for the sciatic symptoms that begin with walking and improve by sitting down. Now, the one thing you always got to be careful when you have a story like that is that to make sure it's not a blood flow problem. They have very similar patterns. If you walk a distance and it starts hurting like crazy, and then you stop walking but don't sit down and it goes away, that's more suggestive of a blood flow problem. If you walk and it's getting terrible and you stop and you stand still and it still is terrible and the only thing that makes it get better is sitting down, again, this is not the case every single time, but that's more suggestive of a spinal problem. What is a mild procedure? Mild procedure is like you go in, it's done by non-surgeons. You go in with like this teeny little rotor-rooter and you try to like take away some of the ligament without actually going into the spinal canal, because you can't go into the spinal canal because you can't see what you're doing. It's done just with like blindly with x-ray. I've never seen it work. Now, the reality is like if it works, maybe people don't come see me. So maybe there are people out there who have it and it works. I am extremely suspicious. The other thing is that one of the problems with it is that it's done by, I've never heard of a surgeon doing it. It's done by non-surgeons. And so if it goes badly and that rotor-rooter goes too far in and chews up the nerves, you got someone who can't fix the problem they just created doing it. So like, kind of like a little bit of a bad setup that way. But I think the main thing is not that someone's going to hurt you, because I think that's luckily pretty rare. I think it's just that I don't think it probably works. What would you comment if laying on one side causes nerve burn in the opposite hip? Nothing. It probably is like a stretch to the nerve that just is positional. So like, don't lay like that. But the real thing is to find out if you have a nerve getting pinched on an MRI. Does Rothman offer prolotherapy? No, we don't. It like I said, I don't exactly know what it is. I know it has something to do with like cold temperature and water or something like that. But there are a number of places that seem to be, because I've been on both sides of the river. It seems to be more common in South New Jersey. And a lot of primary care docs do it. I don't have a lead on where to do it. And in particular, like I said, we have never had someone that knew how to do it or did it. Is leg cramping caused by sciatica? Probably not. I don't know. It depends what you mean. Like if you mean you wake up in the middle of the night and your calf has a cramp, like a Charlie horse, I don't think that is usually from the spine. But people use all sorts of different words to describe, how they feel in their experience of pain. So like if the pattern fit and it felt like cramping pain, it could be. I think that'd be something you have to get in front of a practitioner and explain it out and flesh it out a little bit. Can hip pain be due to sorry, it keeps moving. Can hip pain be caused with an issue in the back? It's in the outer portion in the joint. So groin pain can be from the back. Very rarely, though, it'd have to be the L1 nerve, which is the part that doesn't break down that often. If it's sort of like more like around the butt or the outside of your hip or the your like where the pocket of your jeans is, that is more commonly from the back and less commonly from the hip. Again, with the hip, most common location of hip joint related pain being your groin. I've had sciatic pain on and off for years. I also have a lot of pain at the top of my foot and arch. It's much worse at night when I lay flat. Can foot pain be related to sciatic nerves? It can be. I mean, like the L5 nerve goes to the top of your foot. The outside of the foot and the bottom is the S1 nerve. So like that happens. It's not real common. It's not real common for people to have isolated foot pain, and the reason is because those nerves run all the way down the leg, and just what the pattern you see is usually you got something up top. It doesn't have to be the whole way, it doesn't have to be severe, but it's not real common for people to have isolated foot pain. So, getting them around your back, if it doesn't really look like there's much that matches up, that may be a time to see a podiatrist, and to see if they can sort out what that is. And we do have podiatry. In the last 6 months, I've had back pain for years. In the last 6 months, I've been having discomfort in the buttock and outside the leg down to the top of the foot large toe. That is L5 nerve pain. Perfect textbook description. It's managed by a small dose of tramadol. I mean, if the nerve's pinched, I don't know. That's a tough one. Like, it's a tough one only because what's so bad about taking a tramadol? I don't know, probably nothing. It's kind of like the wimpy medication it's not really narcotic. I don't think you can really get addicted to it. So like if that's not that bothersome to you and you live your life and you don't want to fix it and you're not bothered taking the medication, it sounds like a good strategy for me. If it gets worse and it doesn't work, or you don't want to take it, or your family doctor says he won't give it to you anymore, or whatever it is, then you should look into your back, because it sounds like a perfect description of an L5 radiculopathy or sciatica. Is ice or heat on the sciatic nerve better for pain control? It's not really an answer to that. It's like try them both. This is like a cop out, but try them both and do whatever one works better. It's hard to know. Like ice would be like treating inflammation. Heat would be treating like muscle spasm. If it's just in the butt pain, it could be either of those things, and whichever one works probably tells you what it is and how to manage it. Does radial shockwave therapy and ultra bright red light help, or is there a risk? I don't know what that is. I've never heard of that. Ultra bright red light. I mean, I guess I can imagine it's just red light. I'm not sure how that would change a nerve getting pinched in the inside of your body. And I don't know the shockwave there. sounds kind of scary, but I'm sorry, I don't know what that is, so I can't answer that. Are there useful disc injections that help a disc to reflate and reinflate and recover? Not a chance. Don't spend your money on that. That is not going to work. Do autoimmune problems cause this, like fibromyalgia? Especially RA. I'm not sure fibromyalgia is necessarily an autoimmune problem. RA, I mean, there's a host of problems that can be fibromyalgia I don't think causes a spine problem directly. It can cause pain in the back because that's part of the syndrome, but it doesn't like cause disc degeneration, doesn't cause a nerve to get pinched. RA has some spinal manifestations. It's mostly though in the neck, and to do with instability. So it really it's not something you'd think of would have a lot to say about your low back and sciatica. Would supplements help sciatica? I mean, maybe like this is like kind of where people take someone told me they CMOS. I don't know what that is. But there are a bunch out there. There's like some that are kind of more nerve driven. That's one strategy. The other strategy medications are like the kind of the anti-inflammatory stuff, like things are supposed to just bring the body's inflammation. I mean, they probably work to some extent. Again, it probably depends how bad it is, and if you can rescue the problem just by decreasing inflammation in the nerve, then I would give them, and I would give all those things a try. Unfortunately, probably a lot of them you like pay money for and then you pee them out. But there's probably no harm in almost any of them. What in your lumbar spine can cause widespread myofascial trigger points and spasticity in the fronts of the legs, back of the legs, side apex, side of the legs? The typically band left hip and is not relieved by dry needle and acupuncture trigger point injections. I mean, spasticity, meaning like muscles tighten up and you're, walking really stiff legged and stuff like that. The time that I've seen that be from this, I mean, that may not be spinal at all, but the times I've seen that from the spine is often, and I saw somebody today who's not here who came from follow, but I had a couple like this, that people had that walking pattern for years, and it was thoracic problems that no one ever picked up on. And got pretty bad before someone figured it out. And so that would be the one thing I'd think of if it is truly muscle spasm. That's a tough one because there's a lot of different things we think can cause muscle spasm, and there's a lot of different ideas about what may benefit it. It's not really a spine problem, so I would ask your family doc. But if the spasticity, sort of pattern recognition triggers like a look at your thoracic spine. Is Lin Q a worthwhile endeavor? I don't know what that is. One second. Maybe it's something I don't know, and I know it is by a different name. Oops, I found a hotel. Minimally invasive procedure. Oh, so it's some sort of fusion strategy, a fusion surgery for the SI joint. So, I mean, there's a percentage of people who have real bad SI joint pain. Like I said, it's sort of like 3 or 4 inches off the midline at your belt line. And if this, I've never heard of it, but until just now, but I think that the appropriate person who has kind of really well demonstrated sacroiliac joint problem, SI fusion probably is the way to go. I just don't know that particular procedure. Would a shot in the bursa help? If it's bursitis, so if you specifically are tender when you push over the bump on the outside of your hip, and that is a diagnostic test for bursitis, then there's no real downside. There is an overlap between bursitis because it's on the outside of the hip and L5 nerve pain. Can age degenerative changes or surgery cause decreased height? Yeah, degenerative changes definitely. You can lose an inch. You can lose maybe not an inch, 3/4 of an inch per disc. So you can lose 5 to 6 inches just from your lumbar spine. So for sure. What about nerve ablation for spinal stenosis pain? So nerve ablation is used for one thing, which is burning the sensory nerves that come off the joints in the low back. Those nerves are only sensory nerves and transmit pain signals to your brain. You can't ablate the nerves pinched in spinal stenosis because those are what control your leg function. So if you go in and your L5 nerve is pinched and you burn it, you might get rid of the pain. Actually, you probably have an area of numbness where the L5 nerve pattern goes, and you'd have a foot drop, and it would never come back. So you can't. A nerve ablation is for back pain and for little sensory nerves off the joints. Can pain come from both L5 and S1 and be treated at the same time with steroid shots at both locations? Definitely. Yep. You just order 2 additional level. An injection targeting S1 will probably get some flow to L5, so you might be able to do just the bottom one and not need 2 shots, but you can do 2 shots. I don't do injections, but I know that they do it. I have a T10 compression fracture 3 months ago. Is it common to have side rib pain? Well, depending on how bad the fracture is, if it really collapsed the vertebra, you can pinch the nerve tunnel. Then the T10 nerve wraps around the outside, like at the belly button level, wraps around the outside of your torso and could make it all the way to the belly. So it wouldn't really be from the fracture so much as if there's a consequence of the nerve there. Can you elaborate on the effects of sciatic on urinary bowel changes? So if you have severe stenosis, it terribly pinches the whole nerve sac, it can cause the nerve to not work normally to control your bowel and bladder function. Those can range from the symptoms. In the extreme case, it's incontinence, meaning like you don't know you have to go to the bathroom when you're watching TV and all of a sudden like your pants are warm and wet. Like you didn't even have the urge to go. There's a much less concerning symptom that sometimes is from the spine, often is not, called urgency. That's what people usually get, which is that like they know they have to go. It's just like by the time they figure it out, they got to go like right now. And that can be a combination of like decreased mobility and you're not just a very fast mover, or it could be that you just you can't hold it very long. Those are the 2 most common. Once in a while, you see urinary retention as well. That usually goes along with a spinal cord injury, but it could in theory be from spinal stenosis. What is the best exercise to address these issues? So exercise really doesn't address sciatica. Exercises like core strengthening, abdominal muscle strengthening is relatively effective for treating low back pain. It appears my question was skipped. Oh, shoot. John, let's see. Let me go try to find. It kept updating as I'm doing it. It like changes the spot where I'm looking because if new questions come on, so it's possible that it bumped it up. And let me see if I can search. Try to find it really quick. Not that many questions.
I'll take a look through and find it for you.
Okay, yeah, if we can find it and okay, sorry, I'll go back. Yeah, I really did not see it, and I just looked back.
Oh, I found it. I found it.
Oh, okay, you want to read it?
I've had back pain for years. It has only been in the last 6 months that I've been experiencing discomfort in the butt and outside of leg, down to the top of foot and large toe. Yeah, we discussed this one because
I think that's L5
using
radiculopathy.
tramadol.
Yeah, if you use tramadol, that's enough. fine. I don't think that is anything too bad. If you can't tolerate it, if you can't get it, then that's not an option. And you may need to look into a more direct treatment like an epidural injection, or if you can't beat it in any other way, a surgery. But if you're happy with tramadol, you can get it and it works really well. I don't think there's anything too bad there. Um, Upper hip pain around pocket on the pants with inner thigh groin pain all on one side is likely sourced at S1. Not really. So that actually sounds a little bit like it may be a hip joint. The S1 is butt back of the thigh, not the groin. If the groin crease, like when you're like in the groin crease where your leg meets your crotch, pain in there is usually, if it's from the spine, is L1. It's just like we hardly ever see that because that part of the spine, just based on the shape and the way weight's distributed, it doesn't break down very often. Leg jumps at night wide, not from your spine. That sounds more like restless leg or something like that. The spinal cord, and the nerve roots are a telephone line. They're not doing the talking. They're just passing the signal through. So the leg jumping is a signal. And that the only thing in the human body that makes the signal or is the talking. If the only thing that talks is the brain. So you can have some sort of like nerve discharge from like restless leg syndrome and stuff like that, but strictly speaking, that is not sciatica. Which nerve causes pain in the inside of the knee? L4. So end of the thigh, at the front of the thigh, kind of above the knee, to the knee and the inside of the knee, and then down the inside of the shin is L4 pattern. Unless it's a knee problem.
There's a couple above that I don't think we answered. Can you elaborate on the effects of sciatic on
Yeah,
urinary and
I
bowel
just did.
changes? You did
Yeah,
that one?
just
Okay.
that way.
Sorry.
Yeah, that was incontinence is the worst case. You can get urinary retention or urgency, which is meaning like you got to go to the bathroom right away. All those things, if they're real and they're from the spine, are things that should be treated with surgery because if you let them go, you can end up in a bad space. Compression fracture we talked about. The exercise don't really address sciatica. They can address back pain. Does baclofen help with a lot of spine issues? So baclofen is a muscle relaxant. If that gives you a lot of relief, a little bit suggestive that the thing you're treating is not a nerve problem because it does not treat nerve problem. But like if you have buttock pain and it makes it better, it might be muscle spasm or something else.
I think that's it. I think we got all of them.
All right. Well, if we get any other ones that we missed or whatever, or if we get them later, I will send them along and I'd be happy to type up answers and stuff like that.
Yeah, so I got a lot of messages. Dr. Kepler is taking new patients. My email, I think you guys have my email because you get them from me for reminders about the talk. Shoot me an email and I can get you set up. My phone number is, I believe, also in that. So you can also call or text, whatever works best. And if you have a question that we didn't get to, please feel free to send it over and I'll get it to Dr. Kepler and hopefully we can get you an answer. But thank you so much for doing this. This was
Yeah,
so
absolutely.
informative. And, we can tell just by the level of engagement that it was something that people really want to hear about. So thanks for taking the time out of your schedule.
No, my pleasure. Everybody have a good night. Thanks for tuning in.
Good night. Thank you.
All right. Bye-bye.